I'm John Strum, and this is Real Talk MS. It's May 6th, and we have a lot to talk about. First, I want to thank everyone who sent emails or DMs in celebration of hitting our 400th episode last week. Now that we've hit episode 400, someone asked me what I was going to do. I said I was going to start working on episode 401, and so here we are. This week, I'm talking with internationally recognized clinician and award-winning MS educator, Dr. Barbara Giesser, about the kinds of things that should be discussed during an appointment with your neurologist or MS specialist. But before we get to my conversation with Dr. Giesser, there are a few other things that you should know about. Over the past few weeks, I've shared some pretty gloomy news about drastic reductions in federal funding for the National Institutes of Health and the decision by Congress to defund the MS research program, eliminating the only federal funds that are specifically earmarked for MS research. Well, this week I'm happy and even relieved to share some good news about MS research funding. The National MS Society has announced a commitment of $18.1 million in multi-year funding to support research projects aligned with the Pathways to Cures roadmap, which focuses on three important outcomes: stopping MS, restoring lost function, and ending MS forever. The new projects include 16 research grants and 28 training fellowships and early career awards designed to support the next generation of MS research scientists. Among the newly funded projects is a clinical trial to investigate whether the MIND diet can protect the brain and improve symptoms in people living with MS. If you aren't familiar with the MIND diet, it focuses on brain health by combining aspects of the Mediterranean diet and the DASH diet, or the Dietary Approaches to Stop Hypertension diet. Studies have suggested this diet may help prevent Alzheimer's disease and help older individuals retain cognitive function. Researchers have found that people who eat more healthy components of the MIND diet and fewer of the unhealthy components tend to have more preserved brain tissue in the thalamus, which is a critical relay station in the brain. Another project that's being funded is a study of abnormalities in glucose and oxygen use in the brains of people with progressive MS. And another project being funded will investigate virus patterns in blood and spinal cord fluid samples that may help predict who is at high risk of developing MS. It's sometimes easy to lose sight of the fact that the National MS Society is the largest private funder of MS research in the world, having already invested more than $1 billion in research since its founding. But today, I think it's important to remember that when Congress and the current administration slam the door on funding for MS research, the MS Society is not only advocating for that funding to be reinstated, they're doing much, much more than just talking about it. If you'd like to review a complete list of the research projects that are supported through this investment, you'll find that link in today's show notes. In more good news, 3 research teams have received funding for clinical trial development projects as part of the International Progressive MS Alliance's Experimental Medicine Trial Awards. These development studies are for planning, developmental efforts, and/or validation opportunities, with the goal of these projects growing into full clinical trials to help better understand MS progression and find new treatments for progressive MS. One of the 3 projects being funded is focused on developing an innovative clinical trial platform using exercise-induced fatigability as a way to assess the efficacy of neuroprotective drugs that regulate neuronal energy and learn whether they will improve neurological function in MS. The team will test drugs that have already shown promising results in animal models in both improved motor and cognitive function and neuroprotection. Another project aims to establish the foundation for a future clinical trial to assess the neuroprotective and neurorestorative capability of stem cell transplantation from donor tissue directly into the brain of progressive MS patients. Importantly, the investigators in this project will establish and activate a patient and public involvement group to incorporate patient perspectives into decision-making throughout the process. The third project is designed to attain definitive evidence in models of MS that salbutamol alone and especially in combination with ibutylast changes the properties of injurious microglia normally seen in progressive MS into a non-toxic reparative form. Another outcome is to determine the effect of salbutamol alone and in combination with ibutylast in promoting myelin repair. If they're successful, the team hopes to present a plan for a phase 2 clinical trial to test the efficacy of salbutamol alone or in combination with ibutylast in progressive MS patients. The International Progressive MS Alliance announced a request for applications last year to offer funding for innovative studies that advance our knowledge of MS pathophysiology by either helping us understand how a treatment or therapy works at a cellular level, learning more about the biological processes that lead to the damage of the nervous system in progressive MS, or ensuring that measurement outcomes are consistent. The awards have two different tracks. There are development awards and trial awards. The trial awards are expected to be announced next month, so stay tuned. And if you'd like to learn more about these awards or the International Progressive MS Alliance, I'll invite you to visit their website at progressivemsalliance.org, and you'll find that link in today's show notes. Speaking from my own experience, having served a 7-year term as a member of the Alliance Scientific Steering Committee, I know that from the very beginning of the Alliance, the voices of people affected by progressive MS have been baked into everything the International Progressive MS Alliance does, every initiative that they launch, and every project that they fund. Last week, the Alliance hosted a webcast focused on the Alliance's principles of patient engagement in MS research. The webcast was a deep dive into how the Alliance is implementing these principles as a requirement for research funding. If you'd like to catch a replay of that webcast, you'll also find that link in today's show notes. While we're on the subject of clinical trials, biotech company Immunic Therapeutics has shared the results of a phase 2 clinical trial that's evaluating vidofludimus calcium as a therapy to treat progressive MS. And those results showed that compared to placebo, vidofludimus calcium led to a significant 30% reduction in the risk of confirmed disability worsening among people with primary progressive MS. Additional findings in this clinical trial showed a 20% reduction in disability progression across the overall progressive MS population and a 29% reduction among study participants without gadolinium-enhancing lesions, supporting the efficacy of vidofludimus calcium in non-active secondary progressive MS. This phase 2 clinical trial is an international, multi-center, randomized, double-blind, placebo-controlled, exploratory phase 2 trial involving 467 MS patients between the ages of 18 and 65 at more than 70 sites throughout North America, as well as Western, Central, and Eastern Europe. 152 study participants have been diagnosed with primary progressive MS, and 268 study participants have been diagnosed with non-relapsing secondary progressive MS. All 467 study participants hadn't experienced a relapse in the 2 years preceding the clinical trial. The results of this trial are great news, and I'm looking forward to following up with the folks at Immunic Therapeutics so that we can share further details around this positive showing in their phase 2 clinical trial for vidofludimus calcium. I should also mention that Immunic Therapeutics phase 3 clinical trial evaluating vidofludimus calcium in relapsing multiple sclerosis is ongoing and expected to be completed in 2026. So let's all stay tuned for more news from Immunic Therapeutics. Given what we've been discussing throughout today's episode, it seems like an ideal time to talk about how some of you may be able to participate in MS research yourselves, or you may have a family member who's eligible to participate in the GEMS study. GEMS is an acronym for Genes and Environment in MS, and this study is designed to identify the genetic, environmental, and immune profiles that may increase an individual's risk of developing MS. Study investigators based at Columbia University in New York are interested in developing tests that can help predict who might develop MS in the future. And they're hoping to enroll 5,000 participants who may be at risk of developing MS. Specifically, they're looking for biological parents, siblings, or children of people living with MS, or people with neurological symptoms who have been referred to an MS center for evaluation of those symptoms, or people who have received anti-TNF therapy for inflammatory diseases other than MS, like Crohn's disease, psoriasis, or rheumatoid arthritis, to name a few. Researchers are recruiting from all 50 states, but are currently prioritizing individuals in New York, New Jersey, and Connecticut. Participating in this study will involve completing a questionnaire at the time of enrollment and then annually, and possible sample donations of saliva, blood, stool, urine, and cerebrospinal fluid, possible MRI exams, and possible neurological function tests. Again, the study location is in Manhattan, and if you're interested in learning more, you can visit the study's website or contact a study coordinator by email or phone, and you'll find all those details in today's show notes. The great majority of people living with MS are diagnosed with relapsing remitting MS, which, as its name implies, is characterized by relapses when symptoms worsen, and periods of remission when those symptoms ease, sometimes seeming to disappear completely. Over time, many of these individuals transition to secondary progressive MS, which is characterized by a steady worsening of symptoms without those periods of remission. But that transition from relapsing remitting to secondary progressive MS is difficult to identify. In fact, most of the time, secondary progressive MS is diagnosed retrospectively, sometimes years after it's begun. And that lag in diagnosing secondary progressive MS is not ideal for the patient because relapsing remitting and secondary progressive MS respond differently to different disease-modifying therapies. So someone who's actually transitioning to secondary progressive MS could end up staying on what's become an ineffective DMT for an extended period of time before their diagnosis officially changes and they move to a different disease-modifying therapy. And that time is critical in terms of delaying progression. Now, a research team in Sweden has developed a first-of-its-kind artificial intelligence tool that can accurately detect the transition from relapsing remitting MS to secondary progressive MS, and it can often do so earlier than a clinician can. To build their AI model, the research team used data from more than 22,000 people with MS. The data was collected between 1972 and 2022 by the Swedish MS Registry. Using machine learning, most of this data was used to train and validate the AI model. Following that training and validation phase, data from 3,595 patients was used to test the algorithm. This data set was made up of 2,451 people with relapsing remitting MS, 677 people with secondary progressive MS, and 467 people who were initially diagnosed with relapsing remitting MS and then transitioned to secondary progressive MS in the course of their disease. The AI model was 92.1% accurate at being able to identify and discriminate between relapsing remitting MS and secondary progressive MS at a given hospital visit. Among the 467 people who were initially diagnosed with relapsing remitting MS and then transitioned to secondary progressive MS, the AI model was able to predict that transition 68.5% of the time. And in 26.6% of these cases, the AI tool was able to predict that transition before doctors were able to diagnose it. And one of the unique features of this AI model is it will tell you how confident it is in its own individual assessment. So a doctor using this model in clinic will know exactly how reliable that conclusion is. This means that people transitioning from relapsing remitting to secondary progressive MS can be prescribed the right medication at the right time. And this tool could also prove useful in identifying participants for future clinical trials. The research team has made their tool available online at no cost so that other researchers and clinicians can explore its capabilities. If you'd like to review the details of the study that created this tool, you'll find a link in today's show notes. And if you'd like to suggest that your neurologist or MS specialist checks out this new tool, you'll also find that link in today's show notes. A lot of important things happen during an appointment with your neurologist or MS specialist. Symptoms are assessed, and that assessment should include those invisible symptoms as well. Decisions get made, like choosing your disease-modifying therapy or switching your disease-modifying therapy. Questions get raised and hopefully answered. A lot goes on. In a moment, my guest, Dr. Barbara Giesser, joins me to discuss all the things that should happen during an appointment with your neurologist. If you're living with MS, you may not see your neurologist or MS specialist often. For many people, it's once or twice a year. A lot happens during that appointment, and today I'm talking with Dr. Barbara Giesser about the things that happen during an appointment with your neurologist. Dr. Giesser is an internationally recognized clinician and award-winning educator, specializing in caring for people with MS since 1982. She's received a dozen awards for excellence in education at the local, regional, and national levels. And Dr. Giesser has authored over 100 publications, including peer-reviewed research articles, reviews, textbooks, chapters, and abstracts. One of the earliest conversations a neurologist is going to have with a patient is probably when the patient is first diagnosed with MS. Why does diagnosing MS sometimes take so long? What makes that diagnosis so challenging?
Like any disease, sometimes the diagnosis can take a while. Sometimes it's more straightforward. One of the issues is that we don't have a single 100% fail-proof test for MS. We don't have something like a pregnancy test, for example, where you can do it and the results is either positive or negative. So we have rules, we have guidelines, which were recently updated, and these rules rely on clinical data, the patient's history, the patient's exam. They rely on MRI data. They rely on other data, such as perhaps spinal fluid analysis. And very importantly, they have to exclude other conditions because multiple sclerosis is not the only thing that causes spots on an MRI, and it's certainly not the only thing that can cause some of the more common symptoms, numbness or tingling or fatigue. So we have to be very careful to try to rule in that MS is in fact the cause of the patient's problems and make sure that there isn't anything else going on.
When someone first hears that they have MS, they're rocked. Their mind travels in 100 different directions, and none of them are good. None of them are positive. What advice should a neurologist share with a patient who's just received an MS diagnosis?
I think getting an MS diagnosis, which mostly, as we know, of course, affects young people, and these are people that are starting families and careers and doing their education and living their life. And as my friend Dr. Rosalind Kolb says, the MS is sort of an 800-pound gorilla who comes in and plants himself in your life and says, I'm not leaving. And what I try to tell people is, I can't make the gorilla leave the party, but I can keep him in his place. I think the most important thing that I want to tell a newly diagnosed person is, This is not curable, but it is eminently treatable, and we are going to employ a number of strategies that are going to enable you to live your best life with this disease.
Another early conversation that a neurologist is likely going to have with a patient is going to be about disease-modifying therapies. With more than 20 DMTs approved for treating MS, how does a neurologist go about deciding which DMT is right for a specific patient? And how or when does the concept of shared decision-making enter into this conversation?
I'm really happy you brought that up, John, because this is one of the most important opportunities for the person with MS and their family and the neurologist to engage in shared decision making. As you pointed out, we have almost 24 disease modifying therapies, and this is not a one size fits all. This is not, well, there's one best drug and everybody should take it, and that's the end of the discussion. Choosing a disease modifying therapy is very, very nuanced. That's because there are different efficacies, there are different side effects. So we have to make sure that the person with MS and that the decision that we arrive at is the best for that particular patient. Some people said there's sort of 5 steps in a shared decision-making process. The first is you have to acknowledge that we need to make a decision. In this case, it would be we have to pick a disease-modifying therapy, or perhaps we have to change a disease-modifying therapy. We want to get the information. We want to understand what the disease-modifying therapy is supposed to do and how we will know if it's working or not working. We want to evaluate the options. We want to say, well, this medicine is different than that medicine, and here's why that medicine might be better for you, particular circumstances than the other medicine. And that's where we take into consideration what's unique about that particular patient. What is their MS like? What is their lifestyle like? Do they have any other medical conditions that might impact this? How is this going to fit in their daily routine? What side effects are they most concerned about? That's where the patient's input is very important. And then we want to decide on a therapy, and then we want to implement that therapy. So it's a very complicated process, and it may take more than one conversation.
I heard you mention that when it comes to disease-modifying therapy, it's not a one-size-fits-all situation. When is it time and why is it time for a neurologist to recommend switching a patient's DMT?
That's also a great question. So again, as I said, in order to say when would we switch a DMT, there's basically 3 criteria. One is pretty straightforward. Overall, about 10% of patients will not be able to tolerate any one particular medication, either because they have a bad side effect or they have an allergic reaction or something happens that they just can't take it. So that would obviously be the first and possibly the most serious consideration. The second consideration would be if it's not working. And in answer to well, how do you know it's working? Again, we come back to what are most disease-modifying therapies supposed to do. They're supposed to decrease the occurrence and severity of relapses. They're supposed to decrease inflammation and new lesions, new scars on an MRI. And in some cases, they may slow progression. So we have to evaluate those parameters. And if those parameters are not stable, if the patient is having more attacks or more lesions or getting worse, we may say, well, let's try something else. And the third criterion is, we've got something much better. Let's do this. So those are kind of the 3 guidelines for changing therapies. We now also have some new biomarkers. We can do blood tests, which suggest if a patient is or isn't responding to medication. And I'm not sure we would use the biomarker as the sole criterion, but it's very helpful information.
During an appointment, a neurologist evaluates a patient's clinical presentation, and that speaks primarily to the physical symptoms that patient may be dealing with. When or how do the invisible symptoms of MS, like pain, fatigue, cognitive fog, and depression, to name just a few, how should these significant but less apparent symptoms be addressed?
They should always be addressed whenever they're part of the patient's presentation. And as you just pointed out, they're not something we can test with a reflex hammer or a tuning fork. So that's why it's often said that the single most valuable piece of information that a patient brings to a medical appointment with them is their history. Any healthcare professional is only as good as the information that we get. So any symptoms, any problems that a patient is having, we can't help unless you tell us about them. And as you just pointed out, invisible symptoms are just that. So if we don't ask about it, are you having pain? Are you having muscle spasms? What's your fatigue level like? Have you been depressed? Are you having any trouble thinking? The patient hopefully will bring this up to us. We have a number of strategies for treating invisible symptoms. Some of them involve medication, some of them involve rehabilitation, some of them involve lifestyle changes, some may involve alternative therapies such as meditation. It's generally takes kind of a multi-pronged approach. But the take-home message is just because they're invisible and we can't measure them in some cases doesn't mean we can't treat them, and we can and we should.
Let's talk about treating older patients for a moment. How does MS interact with the normal aging process? Are there any specific considerations, I guess, for older people with MS?
That's a great question. And the short answer is I don't know. But clearly there is an intersection between MS and getting older. As we all get older, we're a little bit slower. We may lose muscle mass. We may have a little bit of cognitive impairment. And sometimes it's a little difficult to parse out what may be due to MS, what may be due to, quote, normal aging. Additionally, as some of us age, we may develop other medical conditions that may impact our neurologic status. We may have to be taking other medications that may interact with some of our MS medications. So it's a little bit of a balancing. There's also been some recent literature about the possibility of stopping disease-modifying therapies in older patients who have been stable for many years, and some of this literature is mixed, and I think we're waiting some more information for that.
One of the things that occurs, unfortunately, often is a patient comes in and doesn't feel that they're really being heard, that their concerns are being addressed. What advice do you have for patients on how to best advocate for themselves within the healthcare system?
That's a very good question. We should all be advocates for our patients. And I think that the most important thing I can do for any of my patients is to try to listen to them. And I hope I try to do that. And the day that I'm not listening to a patient, that's the day that I'm not doing my job. So if you're having a conversation with a neurologist and you don't feel you're being heard, and again, sometimes we don't know that we're not listening until it's pointed out to us. So you might say, doctor, could you please explain that again? Or doctor, I'm not sure I understood your answer to my question about so-and-so. Or if all of your questions haven't been addressed, and the doctor says, well, we don't have time for this, perhaps you could say, well, perhaps I can have a follow-up appointment, or perhaps I might have a phone call or a Zoom visit. But at the end of the day, I think any physician's job is not to tell people what to do, is to give them information so they can decide what's best for them to do. And if we're not listening, we can't give you the best information.
That was some very important advice. Thank you for that. I'm curious, what are the most common myths or misconceptions about MS that you encounter either from patients or the general public? What are people getting wrong about MS?
Well, as I've alluded to, MS is not curable, meaning at this point, we cannot completely stop it and completely reverse the damage. But there's an old kind of joke that the only thing any doctor can cure is pregnancy and a broken leg. So we don't cure most medical conditions, but we treat them. We don't cure high blood pressure, but we treat it. We don't cure diabetes, but we treat it. And the myth about MS is that it may not be cured, but it is eminently treatable. And the three sort of arms of treatment are disease-modifying therapy, which hopefully prevents future damage, symptom management, which addresses not only invisible symptoms, but other symptoms, and lifestyle. And I think what's been most exciting about MS research over the past 20 years or so is the data and the realization that lifestyle changes, diet and exercise and sleep and stress management and staying connected are just as important as any medical or pharmacologic management. And that's something that a patient really has control over.
Exactly. Those are the kinds of things that somebody can do to actually improve their status, improve their quality of life without having to take another pill or injection or infusion, and it's all under their control.
I agree. It's not an either or. What I heard myself telling patients is medications are necessary but not sufficient. Lifestyle is necessary but not sufficient. It's not an either or. You put them together and that's your MS firewall.
That is such a good way of seeing that. Well, Dr. Barbara Giesser, I want to thank you for all you do to improve the lives of people living with MS. Thanks so much for talking with me today.
And I'd like to thank you, John, for giving people with MS the most important tool they have to fight MS, which is accurate information. I love being on your show. Thank you.
That's going to wrap up this episode of Real Talk MS. Real Talk MS is powered by the National MS Society, and you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/401. You'll find that link in today's show notes so you can easily copy and paste it right into an email or a text. And if you have a minute, I hope you'll visit the Apple App Store or the Google Play Store and download the free Real Talk MS app for your iOS or Android smartphone or tablet. It's the best way for us to stay connected. The app will automatically download the latest episode of Real Talk MS. You'll be able to access any of our past episodes. You'll be able to save your favorite episodes. And it's a great way for me to share bonus content with you. The app is free, so I hope you'll download it today. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.